Welcome to the night. This is the first session of this year's Victorian State Committee Scientific Research Oral Presentations. This year's topic is collaboration in surgery. And I'm Matthew Hadfield. I'm the chair of the Victorian State Committee at the College and a vascular surgeon. First, welcome to country. The Royal Australasian College of Surgeons acknowledges the traditional owners of country throughout Australia and recognises their continuing connection to land, waters and community. And we pay our respects to them and their cultures and to elders both past and present. I'd like to welcome you all. I'd like to particularly welcome our two judges for the evening, Damien Lowe and Daniel Foley, who are going to be listening intently and marking your presentations as we go. You know the way things are going to work now. So I think without much further delay, we'll move to our first presenter. The first presenter on the list is Daniel Cox. So welcome, Daniel. Can you hear me? Are you ready to go?
Yeah, all set. Thank you.
Okay, you share your screen and off you go.
Yeah. Okay, so hello everyone. My name is Daniel Cox. I'm a general surgery registrar and PhD candidate at the Austin Hospital. Thank you very much for giving me the opportunity to present our research entitled Low Levels of Hepatocyte-Specific Methylation in Cell-Free DNA are a strong negative predictor for acute cellular rejection requiring treatment following liver transplantation. I've got no disclosures to report. So as we all know, clinical research is grounded in addressing a clinical problem. And our problem is that the current mechanisms for diagnosing acute cellular rejection following a liver transplant are inadequate. We have a very sensitive, non-invasive biomarker in the form of conventional liver function tests for monitoring the graft after the operation. But unfortunately, LFTs are not specific for any one pathology that can occur in the graft following the operation. So essentially, if a patient gets deranged liver function tests, they often end up mandating having to have an invasive graft biopsy, which is obviously highly unpleasant for the patient. So I wanted to research whether we could develop a second tier non-invasive test that was specific for acute cellular rejection to try and rule it out in a certain number of patients and risk stratify them, potentially allow them to avoid a biopsy if their risk was low. So I became interested in the emerging science of cell-free DNA. Cell-free DNA describes non-encapsulated nucleic acids in the circulation. And recently, the analysis of graft-derived cell-free DNA has shown promise as a marker for monitoring organ health. However, up until now, techniques to quantify graft-derived cell-free DNA have largely relied on prior donor and recipient genotyping techniques. That's essentially to establish which of these cell-free DNA fragments are coming from the graft and which are coming from the rest of the recipient's tissues. But this genotyping step is complex, costly, and time-consuming, and that's basically delayed the clinical translation of this science up until now. So I started looking at cell-free DNA methylation. Unlike our genome, which is the same in essentially every cell of our body, the methylation patterns of our DNA differ from tissue to tissue. So I became interested in seeing whether we could harness this fact to look at liver-specific cell methylation in cell-free DNA fragments to determine which cell-free DNA fragments come from the graft and skip that genotyping step with the aim of trying to triage patients who may or may not have rejection. So in collaboration with scientists, hepatologists, and clinicians and surgeons, I was able to develop a non-invasive biomarker that takes advantage of methylation-specific cell-free DNA. And that's modeled on a housekeeping gene called PTK2B, which is a gene that's highly methylated in hepatocytes and not methylated in any of the tissues that we're aware of. And together we designed a droplet digital platform assay to quantify these liver-specific fragments of cell-free DNA from patients' plasma. And we went on, following ethics approval, to design a cross-sectional observational cohort study to quantify this novel biomarker in the blood of liver transplant recipients who had suspected rejection. So we took consecutive patients who'd been referred for a graft biopsy with suspected rejection, all of whom had deranged liver function tests. We took their blood, and then we collected outcome and clinical variables and compared the quantification of this novel biomarker with those outcomes. All in all, we recruited 51 patients over the course of a year. 14 of those patients had absolutely no evidence of rejection on their biopsy. The remaining 37 had various degrees of rejection as stratified there. But ultimately, only 20 of the 51 patients actually required treatment for their rejection, or that this outcome is treated biopsy-proven acute rejection. And that was my primary outcome in this study. So I analyzed the results of the diagnostic performance of our novel biomarker using a receiver operator characteristic analysis. And when I looked at liver function tests, I found that essentially derangement in LFTs was not statistically predictive of that T-bar outcome. However, our novel biomarker significantly outperformed liver function tests in the diagnosis of rejection. But more importantly, at an optimal level that was defined statistically, our biomarker had a specificity of 97% and could correctly exclude that T-bar outcome in 30 of the 31 patients in the cohort. And if you look at on the right there, a number of, is that at time?
No, 1 minute to go.
Sorry. So if you look on the right there, a number of patients in the cohort had other hepatic related pathologies that were not rejection, but were important differential diagnoses in this context, and our biomarker correctly diagnosed them as not being there. We performed subgroup analysis and showed that with patients who were admitted for treatment of their rejection, the biomarker performed even more strongly and was a strong negative predictor when the biomarker levels were low. Liver function tests on stepwise binary logistic regression essentially weren't informative and didn't help. So in sum, I think we've shown that we could successfully quantify graft-derived cell-free DNA, bypassing that genotyping step, which is going to really bring this technology closer to translation into clinical use. We found that low levels of our biomarker were a strong negative predictor for acute cellular rejection. And our biomarker has several advantages. It can be used off the shelf. There's no requirement for any donor tissues. And it's useful in historic patients who've had, potentially a transplant a long time ago. It's not likely to replace liver biopsy anytime soon, but we think it may have a significant role in triaging patients with deranged liver function tests, in stratifying those who may not benefit from that invasive graft biopsy. And here's my acknowledgements. Thank you.
Thanks very much, Daniel. That was really, really interesting. So to the two judges first, questions from you?
Thanks, Daniel. That was a very good presentation. I had a question prepared, and then you answered it with your very last slide. So you sort of just snuck in there beautifully. I was going to say, so essentially, if somebody comes in after their transplant with derangement of the liver functions, and if your biomarker is negative, will you still proceed to a liver biopsy? But you kind of answered that at the end, in which case you said yes, you still would proceed at this point in time.
Yeah.
If I interpreted it.
Yeah, I think so. Yeah, I think we need to do obviously bigger studies. We were powered in this study, but I think it needs bigger studies. And also, obviously, a biopsy can give you other information other than rejection, which could be useful. But 17, I didn't get a chance to mention, but 17 patients in this cohort had abnormal liver function tests that eventually just got better with no treatment, and they ended up having to have a biopsy for it. So that's what we're trying to avoid.
Yeah. Damien?
Thanks, Daniel. It is a very interesting talk. I just wanted to clarify. So this is a negative predictor for rejection alone, or rejection that's severe enough to require treatment? And secondly, can it be used as a predictor prior to transplant, or is it dependent on specimens from the transplanted liver?
Thank you. That's good questions. In answer to your first question, sorry, my dog suddenly decided to speak. In answer to your first question, it does stratify patients who are having rejection at various levels. So whether they need inpatient treatment, whether they need treatment or not, whether they just have rejection on the histology, but don't end up having treatment. but its strongest performance is in that top group who treated biopsy-proven rejection patients. You could apply this to patients who prior transplant, because we've all got cell-free DNA from livers in our body, and I have done that previously, but it hasn't been in a small cohort predictive of ultimate transplant outcome. So could be investigated further, but at this point, it's not seen as useful. Sorry.
Okay, thanks for that, Daniel. How much of that study was yours from conception through to carrying it out?
So it's definitely a collaborative project, with scientists and hepatologists and surgeons, as I said. So some people in our group have looked at cell-free DNA in different contexts before, but the liver transplant and the methylation and the biopsy and the study was my work for my PhD.
Okay, that's great. Thank you. That was really interesting. Thanks for that.
Thank you.
And I think with that, we will, if everyone's ready, we will move on to the next presentation. And next on the list is Jed Hughes. Jed, are you there? And are you ready?
Yeah, can you hear me okay?
I can just about hear you. You can share your screen, and yep, I can see and hear you if you just put your camera on so we can see you, and then ready to go whenever you want.
So my name is Jed. I'm currently an unaccredited ENT registrar at Oliviarolfe Health. This initiative with supporting research was completed at Austin Health in Melbourne. I've got no conflicts to disclose, and this is enhancing pre-vocational surgical training. Pre-vocational surgical trainees have been described as the lost tribe of surgical training, employed into service provision by hospitals, but not yet on college accredited programs. The question arises as to whether or where the responsibility lies in the education and training of these aspiring surgeons. Navigating solo, the path through the pre-vocational space is strewn with obstacles, and these barriers are further compounded by rising competition for accredited positions. An issue particularly pertinent in Australia, where surgical training has seen only modest increases in the past 10 years, despite the number of medical graduates more than doubling. RACs have made significant inroads into the guidance of pre-vocational surgical trainees through the Junior Doctors or JDocs program. They also provide a competency framework that details the expected acquisition of technical and non-technical skills through PGY1 to PGY3. However, much of the responsibility lies with individuals, where relying on serendipitous opportunity and inconsistent learning may compromise performance and well-being. In response to perceived trainee need, we formed a peer-led surgical interest group called Aspire, with support from a hospital-appointed surgeon. We're also fortunate to have backing from the Austin Surgical Trainee Education Committee and giving us access to more senior supports. Aspire aims to provide pre-vocational surgical trainees with education, professional development, and research opportunities in a supportive and collaborative environment. One of its main initiatives was the provision of weekly tutorials. And to determine the need or where needs were, we rolled out a survey using self-perceived competency in critical aspects of the RACS framework. Survey answers were in the form of Likert scales. Weekly tutorials were held over a period of 8 months during the 2020 calendar year, with a follow-up survey to determine improvement over time. Due to the pandemic, though, all tutorials were delivered online, and an online group through social media allowed us to advertise sessions, important dates, and networking opportunities as well. There are a number of identified areas of need. Participants reported high desire for more supports, guidance in applications and research. Low perceived competence was found in answering after-hours calls and leading ward rounds, while technical skills like closing simple incisions also had low confidence, and low confidence being deemed below a mean response of 3.5 in this case. And these were the areas of improvement, though it's worth noting that when results were pulled for both the PGY2 and PGY3 groups, these lost significance, which was somewhat disappointing. Despite this, we experienced positive feedback from participants, and where support is important in trainee wellbeing and shown to reduce rates of burnout, we did find this a little bit more reassuring. We also looked at framework awareness and utilisation. With 58% of respondents reported being aware of the framework, but only 16% were utilising this to guide their professional practice. And in terms of future research that we would be interested in is looking at inadequate uptake and barriers to improving this. In terms of challenges that we face as a group, attendance was often quite variable, and we would look in the future to have protected teaching time or times that suit trainees better. Online tutorials did actually enhance attendance. However, this did make face-to-face teaching, particularly in skills tutorials that we had done previously, quite difficult. And we would hopefully improve with the aim to have a balance in future sessions with resolution of the pandemic. And we also acknowledge that self-assessments are well known to under and overestimate skills, and this is where more accurate evaluation will be valuable along with institutional support.
1 minute remaining.
Thank you. Though there is little previous research available in pre-vocational surgical trainees in Australia, peer-led groups could be a piece in a larger puzzle in supporting junior doctors to meet professional practice needs. Moreover, the utility of online tutorials allows the possibility of cross-institutional support. And this year, the program has established representatives across a further 2 Victorian hospitals. And there's no doubt that individuals ultimately bear the responsibility for learning, particularly in the adult education space, but Aspire aims to support this, not replace it. On-the-job training forms an integral part of professional development, but does rely somewhat on chance. But as shown in this study, peer-led groups may act to bolster this, but institutional support is vital to better appraise trainees' needs and structures established in ongoing evaluation, intervention, and cyclical feedback. Ultimately, this study suggests a need for more support, and we think that there is a potential role for peer-led groups, but is likely a joint effort ensuring that this lost tribe has equitable access to learning and are not only competitive in set applications, but are happy, safe, and effective doctors. Thank you. And a special thanks to Sean Stevens, who was my research supervisor. Thanks.
Okay, thanks, Jed. That was very interesting. And I will hand over for question answers to my colleagues. Whoever wants to ask any questions first.
Thanks, Jed. That was nicely designed. A couple of questions. Have you continued it this year? Has somebody else taken over the reins so you can kind of get like that longitudinal perspective on it?
Yeah, so it's since been taken over. This year they've added representatives at Geelong and the Northern as well. And it sounds like they're making good headway despite, COVID dragging on a little bit. So yes, I'm not sure in terms of further research and monitoring of that, what the plan is there though.
And then the second question was, from an unaccredited registrar perspective, obviously you get a lot of variability in both the rotations that people are doing and what they're interested in doing, next year or the year thereafter. So how do you try and tailor it to achieve those goals that you set for yourself when one person will want to do ENT and the next one will want to do, the Antichrist of ENT?
Yeah, that's a really good question. And I think that it contributes to the variance in attendance. So it was aimed at PGY 2 and 3, which at the Austin are surgical residents and some step-up jobs as well. And we did see that people were quite picky about what they wanted to attend. And part of our aim, though I sort of wasn't really covered in this, was covering skills and things for different rotations and different specialties and trying to give people access to a taste of different specialties as well. And we tried to boil down to core concepts as well in terms of important things to cover if you're, say, on ED, like a common. So we tried to supply skills that would be applicable to people of various interests as well. But those were tricky. And then focusing overall skills, so things like, leading a ward round or different leadership skills or difficult end-of-life conversations and that sort of thing, which people could use in all specialties and interest areas.
Okay, thanks. Damien, have you got a question?
Thanks, Jed. Definitely an interesting and topical field of study. Just a couple of things. What was the size of the cohort involved in the study? And have you looked at whether it improved outcomes in the sense of, did it increase engagement with research? Did it increase the likelihood of projects being completed and accepted for publication or presentation at conferences? Did it improve the outcome of applications for training?
That's a very good question. I realized too when I was watching Daniel Cox's presentation that I didn't actually have our numbers there. In terms of PGY 2 and PGY 3, each group is about 12 and I believe 15. And we had over 80% response rate. So I think the first group was something like 23 and the follow-up was about 2022. And I should have that included in there. So thanks for that question. In terms of outcomes, we didn't measure that, and that would be really something that would be a very good idea for future research. We did look at overall perceptions of people wanting more supports and more guidance for research and that sort of thing. And in the PGY 2 group, it was found to reduce, but only in a small proportion.
Okay, thanks. And thanks again for your presentation, Jed. That was great.
Thank you very much.
And with that, we'll move on to our next presenter. And the next one on my list is Chim Sher Ting. Are you there?
Yep, I'm here.
There you are. Fantastic. You can share your screen, and whenever you're ready, make a start.
All right, so good evening, everyone. Today I'll be presenting on pre-treatment peripheral immune cell ratios, namely neutrophil to lymphocyte and monocyte to lymphocyte ratios as prognostic biomarkers for glioma patients. Gliomas are the most common primary tumor of the central nervous system. And classically, gliomas were categorized into 4 tumor grades based on histological characterization. Glioblastoma is the most aggressive form, and the current standard of care involves surgical resection, followed by radiotherapy and adjuvant temozolomide with a median survival of 15 months. In glioma patients and other neurological conditions like stroke, the Modified Rankin Scale, or MRS, can be used to evaluate functional outcomes. It is a 6-point scale where a score of 0 indicates no symptoms and disability increases across the scale until a score of 6 indicates death. Currently, elevations in immune cell ratios are thought to be a reflection of the whole systemic response to malignancy. As a response to malignancy, inflammation occurs in the glioma microenvironment, resulting in increased permeability of the blood-brain barrier. This causes immune cells to enter the tumor mass, and interactions between immune cells and neoplastic cells can contribute to the pathogenesis and progression of the tumor, depending on the ratios of immune cells. Studies have investigated the association between neutrophil to lymphocyte ratio, or NLR, and survival outcomes in glioma patients. But few studies have looked at the association between immune cell ratios and other prognostic outcomes, such as functional outcomes, MRS. Few studies have investigated the role of monocyte to lymphocyte ratio, or MLR, in prognostication. The primary objective of this study is to evaluate the ability for immune cell ratios, NLR and MLR, to predict overall survival, or OS, and MRS at admission 6 months and 12 months post-diagnosis. The secondary objective of this study is to explore the relationship between immune cell ratios and clinical pathological parameters, namely tumor location, tumor size, tumor grade, IDH1 mutation, and MGMT promoter methylation status. Both of the latter are thought to be prognostic markers for gliomas as well. This study is a retrospective cohort study. Medical records of glioma patients diagnosed between 1989 and 2018 at Royal Melbourne Hospital were retrieved through the hospital database. The inclusion criteria included no cancer-specific treatment in the past year and no prior systemic steroid or anti-inflammatory drug use, as these have the potential to affect immune cell counts. Based on the inclusion criteria, 64 glioma patients were included in the final analysis. Patient information was then collected from inpatient and outpatient records. And the blood counts of patients were collected from pathology records from the time of first presentation with glioma symptoms to the last blood count before treatment. This was done as treatment affects immune responses. Receiver operating characteristic analysis, or ROC analysis, were used to calculate the optimal cutoff value for NLR and MLR that had the maximum combination of sensitivity and specificity for predicting MRS. The cutoff values were used for subsequent analysis. The Kaplan-Meier method was used to estimate overall survival, and Cox hazard regression analysis were used to determine prognostic factors for OS. UNPAT t-test was used to evaluate MRS, and binary logistic regression analysis were conducted to determine prognostic factors for MRS. Continuous variables were evaluated using UNPAT t-test or Mann-Whitney U-test, and categorical variables were evaluated using the chi-squared test. Based on ROC analysis, we identified a cutoff value of 4.7 for NLR and 0.35 for MLR. We found that higher NLR values of more than 4.7 was associated with a higher mean MRS of 3.31 versus 2.4 at admission and 3.6 versus 2.44 at 6 months. Patients with higher NLR were more likely to report poor functional outcomes at admission and at 6 months. There was no association between NLR and MRS at 12 months, and no association between MLR and MRS. We found that median OS was significantly shorter for patients with a higher MLR of more than 0.35 than for patients with MLR less than or equal to 0.35, and there was no association between median OS and NLR. Higher pretreatment NLR of more than 4.7 was associated with a larger tumor size of 5 or more cm. However, NLR and MLR were not associated with tumor location, tumor grade, IDH1 mutation, and MGMT promoter methylation status.
1 minute remaining.
Some studies have shown that neutrophils and monocytes support tumor growth by secreting androgenic factors, while lymphocytes suppress tumor growth by eliminating nascent cells. Hence, elevated NLR or MLR with a higher neutrophil or monocyte count and lower lymphocyte count leads to an overall net effect of promoting tumor growth, which could explain the poor prognosis in such patients. And today, this is the first study to demonstrate an association between immune cell ratios and MRS in glioma patients. The study demonstrated the utility of NLR and MLR as accessible and minimally invasive prognostic markers in glioma patients. And higher NLR is a predictor of poorer MRS at admission and at 6 months, and is associated with a larger tumor size. Higher MLR is a predictor of poorer OS. Our findings suggest that immune cells can serve as prognostic markers, which allow us to identify high-risk patients in need of further treatment. Our findings also advance understanding of the role of immune cells in glioma pathogenesis, which allows for the development of therapeutic targets. And larger prospective trials can be used to validate the findings of this study, and future studies can clarify the role of monocytes and neutrophils in glioma pathogenesis. And this is the end of my presentation, and this is a graphical abstract of what I've presented. Thank you for listening.
Thank you very much for that. Thanks for your presentation, and I'll hand over to Daniel and Damien.
Thanks for the presentation. So did you go through 30 years worth of Royal Melbourne case notes?
Yes, I did.
That must have been incredibly painful, especially at Royal Melbourne. So, how many patients were identified with glioma? Was it just the 64 that you found, or was there a lot more glioma patients and this was just the ones that met your inclusion and exclusion criteria?
So there were a lot more patients than that, but yeah, based on the inclusion criteria. So we actually had to make sure that like quite a few factors could be met. Like a lot of the patients, they actually started their steroid treatment pretty early, and even before they actually had their blood test results reported, and hence we couldn't actually use those patients because we didn't want anything like steroid treatment affecting the immune cell counts. So in the end, that caused us to eliminate quite a few patients, and we ended up with like 64 patients.
Yeah, because that was going to be my following question, was sort of going to be related to the timing of those two things. It can be incredibly difficult to work out timing of what's happened exactly when in a previous hospital admission. So did you do that simply manually, by just trying to find the dosage administration time on a drug chart versus a laboratory collection time?
Yes, yep, I did. So I matched that up. I matched the date and time. Yep.
Wow. That would have been a lot of results.
Okay, thanks. Damien, did you have any questions?
Yes, thanks very much for your presentation. I was just going to ask, you said that these ratios are sort of markers of general physiological stress or systemic inflammation. So how have you sort of determined that they are specific prognostic markers for glioma per se, and how is that going to be useful practically as opposed to poor prognosis in a patient who happens to have glioma but other medical issues that lead to these ratios being altered?
Okay, so currently they're actually doing studies for these ratios in other conditions as well. But in terms of glioma patients, we intend for this ratio, if it ever gets used like for prognostication, we intend for it to be used in combination with other markers for glioma patients, because it's then that it can provide a more holistic view of the prognostication. So in terms of these ratios, it can be used in combination with like tumor size and, like I mentioned earlier, IDH1 mutation and MGMT promoter methylation status, because all of these are also prognostic biomarkers for glioma patients. So they can all be used in combination to determine the prognosis, and from there they can determine what's the best treatment which they would like to opt for. Would they like to opt for surgery or with chemoradiotherapy? And right now they're actually doing studies for this particular ratios in other conditions as well. So I guess what can be further developed in the project is that they can actually maybe results from the other studies, as well as we could take this study a step further and actually examine like glioma patients with other conditions as well, because in this case we actually excluded patients who actually have coexisting like comorbidities, such as coexisting tumor diagnosis, because we didn't want the other tumor diagnosis from affect the neutrophil to lymphocyte or monocyte to lymphocyte ratios. So in this, we just kept it strictly to glioma patients, but in future studies, we can actually expand that to actually look at glioma patients with other conditions and determine how it affects the pre-treatment NLR and MLR.
Okay, thank you.
Thanks very much, and thank you again for your presentation. Really interesting presentation.
All right, thank you.
Thank you. And we'll move on to our next presenter, and the next presenter on the list is Oliviarolfe. Olivia, are you there?
Yes, I'll just share my screen.
Yeah, we can start to see your screen. So whenever you're ready,
Great.
off you go.
Okay. So good evening, everyone. My name is Oliviarolfe. I'm a final year medical student at the University of Notre Dame, Sydney, based at the Ballarat Clinical School. It's my pleasure to present my research tonight, titled Combined Photodynamic Therapy and Transpupillary Thermotherapy for Small Choroidal Melanomas. So choroidal melanomas are a type of intraocular melanoma, and intraocular melanomas can affect any part of the uveal tract, i.e. the iris, ciliary body, or the choroid. Uveal melanomas are unlike their cutaneous counterparts, particularly in regards to treatment. Unfortunately, the recent advances in treating metastatic cutaneous melanoma are not effective for metastatic uveal melanoma. And while it is a rare disease with an incidence of 4 to 6 per million per year, it is devastating once it has metastasized, with the prognosis for these individuals being 6 months with systemic treatments. Hence, the aim of current treatment regimens for uveal melanoma is to achieve local control. Within uveal melanomas, choroidal melanomas are the most common. Choroidal melanomas, as you can see, are quite a heterogeneous group, and different lesions carry different risk profiles. One of the most important risk stratification criteria is height. So smaller tumours have a lower mortality, as they have demonstrated lower rates of metastasis compared to larger tumours. They're also associated with lower morbidity, as they are usually asymptomatic at presentation. They are often found incidentally on optometry review. But despite the more favourable mortality and morbidity of small choroidal melanomas, currently they undergo the same aggressive treatment as their larger counterparts, including enucleation or brachytherapy. While these methods confer excellent tumour control, they are associated with visual loss. Less aggressive treatment modalities, for example, laser therapies such as transpupillary thermotherapy, herein referred to as TTT, and photodynamic therapy, herein referred to as PDT, have been investigated as localized treatment options for choroidal melanoma. And while they have a much more favourable side effect profile, they are unfortunately associated with higher recurrence rates when used in isolation. But the reduced risk to the patient's life in smaller tumours means that we can at least shift some of our focus from preserving life with excellent tumour control to preserving visual acuity, and which we think that can be achieved by using these less aggressive laser therapies such as PDT and TDT. So accordingly, this study aimed to determine whether combining the two forms of laser therapy confers a lower recurrence rate compared to being used in isolation while maintaining visual acuity. So this was a retrospective interventional non-comparative study which ran from 2015 to 2020 and included 46 individuals who had small treatment-naive choroidal melanomas less than 3 millimetres in height without evidence of metastatic disease. So each individual underwent a full eye examination and then the combined treatment, i.e. the PDT and then immediate TTT laser. They were followed up regularly and had further treatment if there were signs of recurrence around the edge of the tumour. So here are our results. In terms of baseline characteristics of our cohort, you can see that our cohort was fairly evenly split by sex. The mean age was 60. The initial best corrected visual acuity was excellent at 6/6 and an average initial tumour height of 1.93. Our mean follow-up period was 18 months, but you can see here that this did range between 3 and 52. And most patients required only one treatment. And so in terms of looking at tumour height at initial review compared to the last follow-up, you can see that there was a statistically significant reduction following the combined therapy. We can also see by comparing the mean best corrected visual acuity before and after the treatment at the last recorded review, there was no statistically significant impact upon visual acuity. The patients were then allocated into one of 3 groups according to tumour response, so either full response, partial response, or recurrence. And you can see here that our recurrence rate was 9%. Through using analysis of variance and cross-tabulation analysis, it was determined that there was no difference between outcome groups in terms of their baseline characteristics, except that patients requiring more rounds of treatment were more likely to sit in the recurrence group. Through an ordinal regression, it was determined that there were no baseline characteristics that predicted which outcome group an individual would sit in. In terms of our complications, 1 patient developed metastatic disease, and our rates were similar to previous single laser therapy studies.
1 minute remaining.
So referring back to our aim, we hoped that our combined therapy improved the recurrence rates of single laser therapy while maintaining visual acuity. And that's what we found. So our rate of 9% recurrence was a marked improvement compared to PDT alone, which is 44% recurrence, or TTT alone at 32% recurrence. And importantly, it was comparable to brachytherapy, which is the current mainstay of treatment. And we also saw that visual acuity was maintained. And while our results are promising, we acknowledge the limitations of our study, including our short minimum follow-up time, the reasonably modest sample size, although it is difficult with such a rare disease to have larger cohorts, the lack of comparator group of an observational only approach, and the lack of histological confirmation of melanoma, although biopsy is not routinely performed in this area. So in conclusion, our study presents combined PDT and TDT as a promising treatment for small choroidal melanomas, which confers excellent tumour control while allowing for the maintenance of visual acuity. Thank you for your attention.
Thank you, Olivia. That was a really interesting presentation. I'll hand over to my two colleagues. Who wants to go first? Daniel.
Why don't you fire away, Damien? I've been hogging first pole position.
I just thought we were going alphabetically. That's why, Dan. Olivia, thanks very much for the presentation. So there's an interesting statement. So there's normally no histological confirmation prior to treatment with these tumors. It's based just on appearance. Is that correct?
Yeah, that's correct. There's a sort of set of risk factors that have been validated to clinically diagnose choroidal melanoma, and it's based on their appearance, as you said. So whether they have pigment, their height as well, fluid, subretinal fluid, those kinds of things, as well as their imaging appearance on ultrasound and OCT. Yeah, that's how it's usually diagnosed.
So given that it's not based on histological diagnosis, does this therapy impede ability to detect, subsequently detect recurrence earlier and reduce the risk of metastasis?
No, because it really wouldn't be any different to the other therapies, I suppose, and the looking at recurrences really happens around the edges of the lesion. In particular, that's kind of what they monitor for, which is sort of easily seen on bifundoscopy still. So it doesn't really impact the monitoring going forward. Yeah.
Thank you.
Okay, thanks. Daniel?
I just put it in my piggy bank.
Sorry, I'm getting into it. The results of this, the results of your study obviously imply that the department has just transitioned to this treatment as their gold standard treatment, as their first approach, as opposed to sort of the brachytherapy or anything else that they're using. Did they do that as part of a research project, or was there something else that inspired their research, or you've sort of, they just kind of arbitrarily decided to do that change and you've been able to look at it in retrospect?
There was a previous study published in the early 2000s using PDT and TTT, but it was with a different dye for the photodynamic therapy. So photodynamic therapy uses a photo-enhancing dye. We used verteporfin in this study, whereas the previous one used ICG dye. And they had really good results as well, very similar to our own. So I think that's what inspired it initially. So yes, I suppose the difference is the dye. Great to see your son so interested in my talk as well.
He's very keen to get onto opt-out training, so he thought he'd better start now if he wants to be successful.
Good.
So does that mean, so is it then a globally accepted standard, or that's unique to this particular unit?
No, for some reason it hasn't really been uptaken. I think the brachytherapy probably is really overtaken because it has such good tumor control, really, that sort of has overtaken the mainstay. For some reason, this has kind of been sort of lost as a treatment modality. It's not commonly used in centres in Australia, that combined therapy, but it has been shown to be effective. Yeah.
So an RCT of this versus brachytherapy is your next planned project, I presume?
Yeah. Yep. It inspired me. Thank you.
Okay, thanks, Daniel. And thanks, Olivia, for that interesting talk. We'll move on now to our next presenter, and I've got Luke Fairweather down as the next presenter. Are you there, Luke?
Yeah, thank you, Mr. Hatfield. Share my screen. All right, can you see that?
Yeah, we can see that. So whenever you're ready, you can make
Beautiful. I'm Luke. I'm one of the general surgical registrars at Western Health and presenting a novel approach of how we successfully isolated a high output enteroatmospheric fistula with negative pressure wound therapy. There we go. We have no conflict of interest to declare. The challenge of an open abdomen becomes even more complex in the setting of an enteroatmospheric fistula, where the communication between the intestinal lumen and the atmosphere is a devastating postoperative complication, resulting in a particularly challenging management problem. Spontaneous cases of healing are rare. This is in part as there's no particular overlying soft tissue or a real tract from the fistula formed. Spontaneous closure is more common with some of these factors, however. There's no fixed algorithm for treatment of these fistulae. Instead, surgeons need to develop their own, often unconventional techniques and match those to the specific patient and specific wounds and adjust them as time goes on. These can be classified by a number of different means, so including anatomic location, the volume of fistula output, location within the open abdomen with deep ones resulting in sepsis, further complicating the management problem, and the number of fistula openings. So onto our case. We had a 48-year-old gentleman who had a pancreatic-sparing D2, D3 duodenectomy for a symptomatic inflammatory pseudotumor who'd previously had 3 admissions to Melina requiring transfusion. His course was complicated by a duodenal leak requiring an emergency Whipple's procedure. Day 9 after his Whipple's procedure, his midline laparotomy wound started leaking enteric contents, and a further return to theatre found perforations in the pancreaticobiliary limb, secondary to pressure necrosis from his nasogastric tube. Given the severe adhesions, the bowel was unable to be safely mobilised, and he had multiple operative attempts to control the leaks with suturing, T-tubes and fat pedicles without success. Unfortunately, inevitably, the abdomen became frozen and he developed multiple large enteroatmospheric fistula with pouting small bowel mucosa, which you can see here within his wound. Ultimately, after multiple failed attempts with commercial and products based on review of the literature, we found creating small donuts from vac foam, we were able to successfully isolate the fistula, and each vac would last for 48 to 72 hours. So how do we do this? From terms of step-by-step guide, we had a wound that looks like this. We placed white foam over it initially until there was sufficient granulation tissue. Using the black foam, made a donut and covered that in tegaderm, removing the excess tegaderm and placing stoma seals around it and to give it a glazed appearance, and placing that on the granulation tissue surrounding the fistulae, getting a seal using stomal paste, surrounding the area with black foam, and then connecting this to a negative pressure wound therapy system. And these are the sort of results that we had for this patient. So that's his initial open abdomen with a 19 by 9 centimetre wound. This is at 1 month and at 4 months. This novel vac donut approach allowed us to control the large volume effluent while simultaneously applying negative pressure to the surrounding wound bed, as you can see here. We continued this for 6 months until the tissues were suitable for a definitive adhesiolysis, excision of the fistulae, and a staged abdominal fascia closure with bridging mesh. He was admitted for a total of 181 days and then discharged home. And this is the end result just after his staged closure procedure. So onto a discussion, some principles of treatment. So the absolute best, treatment principle for this is prevention, to avoid getting an enteroatmospheric fistula on open abdomen. And here are some factors that can prevent these fistulae. Also, the duration of an open abdomen is another risk factor. By protecting the bowel, I mean covering with omentum, not putting anything directly on the bowel. How we support our patients through this process and also sort of SNAP principles. So management of skin and sepsis, sometimes it can involve diversion of proximal bowel. However, this is often impossible in this patient group due to the hostile nature of their abdomen. Nutrition, which includes reducing fistula output, reducing GI secretions with PPIs and pancreatic secretions with octreotide. These patients have enormous catabolism as well as large losses, so they often need parenteral so parenteral, like TPN and enteral treatment. This patient had a FRECA, has then converted to a PEG-PEG tube. Definition of anatomy, I mean CT scanning, fistulograms, and oral nasogastric contrast. And they need a plan to define, to return them to normal anatomy and to define as definitive management. And this usually requires 6 to 12 months to have a soft abdomen decrease the risk of bowel injury. The treatment outcomes here are spontaneous closure, which is ideal but rare in these patients. Primary excision, which is again great, but often impossible due to the extensive peritoneal adhesions and nature of a frozen abdomen. And as
1 minute remaining.
Thank you. As such, we need bridging therapy until a relaparotomy excision of the fistulae can be achieved. And the main goal described in the literature in all these techniques is isolation of the fistula opening from the open abdomen to control the effluent while allowing time for the abdominal wall to granulate. Here are some different options that are listed in the literature, and skin grafts, local closure, and fibrin glue are unfortunately rarely successful. So this is the glazed donut that we were able to design to deal with this problem for this patient. And the large loss of proteins, fluid, and electrolytes, in addition to the stressing nature of the fistula and open abdomen, can be a challenge for both patients and doctors alike. They require the highest level of multidisciplinary care for optimal outcomes, and certainly can't thank our stomal therapy team and wound care nurses enough for their help. Here are some references I used in science talk, and I might hand back over to Mr. Hadfield for questions. Thank you very much for your time.
And thanks so much, Luke, for your presentation. Difficult problem. I'll hand over to my colleagues who may have some questions about the technique and the problem.
Thanks, Luke. Certainly a very challenging case, and I guess firstly, congratulations on keeping the patient alive. Certainly had our fair, unfortunately, we've had our fair share of these sort of patients over the years. And obviously use several different techniques in terms of managing these. What specifically do you think is the novelty or the advantage of this technique that you've described?
So in reviewing the
application.
Yeah, so thank you for your question, great question. And in terms of the other options of the negative pressure therapy, they all essentially isolate the fistula from the opening, but haven't been able to achieve this in a combination with the other negative pressure system. So some of them involve having direct contact on the fistulae themselves, and that then sometimes cause further problems with sort of a spouting mucosa. And we tried several of those other methods in this patient, and unfortunately they just didn't work.
So the idea is to your idea is isolating the actual fistulous opening from the rest of the back foam by using the stoma paste. That's
correct?
Am I
yes.
interpreting that correctly?
That's correct. Yes.
Okay. Thank you.
Thanks. Any questions, Daniel?
Oh, certainly a novel technique. How did you come up with it, or who came up with the idea of creating a Krispy Kreme?
So by we, I mean, so their team is in the unit. It was an ongoing problem for this patient for, unfortunately, some months, and eventually we're able to get him day leave and try and get a plan for him. But in terms of who came up for it, it was largely the fellow working the unit at the time. Looked through a lot of cases, and we tried several different commercial products, and several of those negative pressure wound therapy options I've listed there, and they just didn't work for him. And so this is eventually something I came up with that got him to 48, 72 hours and made it a manageable thing. He was able to get up, he was able to walk around, and thankfully then able to start having day leave.
Right on. I thought Krispy Kremes were American rather than Canadian, but Canadian fellow could steal from across the border.
Okay, thanks, and thanks very much, Luke, for that.
Thank you for the opportunity instead.
Okay. Okay, we'll move on to the next presenter. Have we got Yi Yong?
Hi, yeah.
Yeah, there we are. Okay, if you want to share your screen, we'll see if we can see it.
Yeah, can you see it?
Off you go whenever you want.
Okay, so hi everyone, my name is Eon and I'm a final year medical student from Deakin University based at Bowen Health. So today I'll be presenting my research on the triage of elective surgery during the post-pandemic recovery phase. The COVID-19 pandemic has had a strong impact on the triage of elective surgery in Australia. And during the peak of the pandemic, elective surgeries either have been postponed or cancelled to ensure that hospitals have enough resources to respond to a surge in COVID-19 cases. and this includes bariatric procedures. When elective procedures resume, providers will be challenged with determining the best way to triage a significant backlog of elective surgeries. However, due to the progressive nature of obesity, delaying bariatric surgery increases the risk for morbidity and mortality. Therefore, a clear framework to mitigate harm for patients should be established. My discussion today will be focusing on the key concepts that influence triage system for bariatric surgery and the surgeries to help with the prioritization during the post-pandemic recovery phase. Bariatric surgery is currently the most effective treatment for severe obesity, and the guidelines recommend bariatric surgery to be considered after non-surgical interventions have failed for those with a BMI greater than 40 or greater than 35 with one or more of obesity-related complications. There is also an extensive preoperative assessment to consider the risks and benefits for patients undergoing this surgery. The justification for triaging patients during a pandemic is based on utilitarianism, and it's the ethical principle of maximizing benefit with the goal of producing the greatest amount of good for society. In resource allocation, it is argued that the resources should be allocated to maximize the number of lives saved. During a pandemic, most of the resources were directed to preparing for the potential surge of ICU patients and the emergency surgical cases. Patients waiting for bariatric surgery is unlikely to fall under this category because there is a long planning process that involves in the preoperative screening and optimization. Therefore, prioritizing the elective surgery based on emergency will not benefit the candidates waiting for bariatric surgery. Secondly, the current triage system for elective surgery also prioritizes procedures that can be disabling for patients. For instance, cancer surveillance such as colonoscopy, mobility restoration procedures such as knee and hip replacement, and reconstruction surgery for tumor removal or post-cancer procedures, all of which bariatric surgery does not qualify. According to the current way of triaging for elective surgery, it is very easy to exclude bariatric surgery on the top of the priority list. But how can we redefine the criteria that measures the suitability of being prioritized in the queue? We can therefore examine the use of quality of life as a criteria. The population waiting for bariatric surgery are often obese and live with many other diseases. For these patients, bariatric surgery improves their quality of life and health outcomes in the long term. From this perspective, quality of life can be measured in these patients through their physical function, mental health, and social well-being. Restricting bariatric surgery increases the hospitalization secondary to the complications of their comorbidities, and they have a higher possibility to experience suboptimal mental health from the prolonged waiting time, leading them to regain their weight and fall back into their unhealthy habits. Patients that were non-urgent will also eventually become urgent, resulting in a surge in bariatric surgery demand. But unfortunately, demand is already much greater than supply, so consequently, more patients will suffer. Moving forward, the prioritization for elective surgery can potentially include the quality of life gain and the impact of the surgical intervention to the patients. In general, if patients are well enough to undergo surgery, preference should be given to those with the highest risk of morbidity and mortality from their disease, and where surgical intervention can reduce the risk. This can be applied to patients with poorly controlled type 2 diabetes, increased cardiovascular risk, or severe obstructive sleep apnea. Based on the clinical indications, preoperative screening and monitoring may be done to improve their outcomes after surgery. In the process of waiting for the surgery, programs that could improve surgical outcomes should be provided. Extra support, such as the involvement of the multidisciplinary team, should be provided, including a dietitian, physiotherapist, psychologist, and a social worker. By having a comprehensive weight maintaining program for the patients prior to surgery, they are more likely to follow their routine and continuing treatment. A couple of important considerations is that 89% of bariatric procedures are performed in the private hospital. Furthermore, thank you. 75% of the weight loss related procedures billed to Medicare are adjustment, revisions, and removal procedures. So the recommendation will mainly benefit patients who are self-funded or have private health insurance. Future directions will be about how can we explore the outcomes after the surgery and gathering information, such as the BMI and chronic disease status, when we use quality of life as a measure to prioritize bariatric procedure. Other potential analysis to look into more depth is the possibility to extract data to give us a clue as to when MDT are being used more often, so that they could be evolved based on the need before or after operation. Overall, it is essential to think about the patient factor, disease-specific consideration, and the use of resources to ensure a fair triage system. But it is equally important to consider the dynamic situation that we are in and how recommendations will constantly change as COVID-19 pandemic continue to evolve. Thank you for listening, and special thanks to my research supervisor, Dr. Jacqueline Sabat. Thank you.
Okay, thank you very much for that very topical presentation. We'll get some questions from the judges.
Thanks very much. You nothing to do with you, but the timing is amazing, given that at 5 p.m. yesterday, the government cancelled all bariatric surgery.
I actually did this research in June, July. So that's when there was like a flattened curve. So we're kind of in the hopefully post-pandemic. But yeah, they canceled the elective surgeries again this month.
Yeah, but no, overall, I mean, I think it's a very valid point. It's certainly a marginalized group in our society, and they're one that we, as doctors, not just surgeons, but all groups of doctors, probably fail to advocate for very well. So I think it's, I think it's definitely a step in the right direction in terms of us trying to sort of promote the overall health outcomes of our communities. It's really more of a statement than a question, but yeah.
Thank you.
Yeah, thanks, Daniel. Damien?
Yeah, and this is probably going to be more of a comment rather than a question. One of the downsides of trying to adopt a utilitarian approach with bariatric surgery especially is the numbers needed to treat in order to achieve utilitarian outcomes are basically impossible to achieve with the supply that we have in terms of being able to treat the number of obese patients. So based on what you've researched so far, where do you see yourself going and with this sort of topic and in terms of practical application?
Yeah, so what I'm planning to do probably in the future is to actually using quality of life as a measure to see if it changes anything for the patients when when other health professionals are more involved in the care of the patient, since that we are still the pandemic is still ongoing and more support is definitely needed. Yeah, so.
Thank you.
Thank you. Thank you very much.
Thanks.
And thanks very much for that presentation again. We will move on to the next presentation, and the next name on the list is Sophia Gogos. Are you there?
Yes, I am. Thank you.
Yeah, and I can see it. So whenever you're ready and set up, off you go.
So, hello everyone. My name is Sophia Gogos, and I'm a surgical resident at Alfred Health. Today, I'll be presenting the findings of our systematic review titled "What We Know About Intraoperative Radiation Exposure and Hazards to Operating Theatre Staff." I have no conflicts to declare. Since the advent of the mobile C-arm in 1955, fluoroscopy has become an invaluable tool in modern surgical practice. Consequently, operating theatre staff, including surgeons and trainees, are at increased risk of occupational radiation exposure. There is a significant body of data quantifying occupational radiation exposure during various surgical procedures. However, there is very little robust peer-reviewed and validated research on the long-term health effects of frequent intraoperative radiation exposure. In the era of COVID, occupational safety, including appropriate personal protective equipment, targeted education, and robust clinical guidelines are more important than ever before. The aim of this systematic review was to identify and analyse the health effects, hazards and risks of radiation exposure among operating theatre staff, including pregnant staff. We hope the results will help to inform the development of the first nationally endorsed radiation safety guidelines specific to surgeons and surgical trainees in Australia. A systematic review of published literature was performed through to February 2020 for 4 databases using a standard PICO format. Included studies were those published or translated into English, controlled and prospective trials and cross-sectional studies reporting on radiation exposure and associated hazards to operating theatre staff. The search of 4 databases yielded 318 results, with a further 2 identified through searching reference lists. 276 unique studies underwent title and abstract screening by 2 independent researchers. After full text assessment and exclusion of research, a total of 6 studies were analysed. Loretta Chu, an orthopaedic surgeon at Stanford University Medical Center in California, conducted a cross-sectional survey of 505 practicing or retired female orthopaedic surgeons and compared self-reported cancer diagnosis within 17 years of the survey with the sex, age, and race-adjusted population. Their results demonstrated a 2.9-fold greater prevalence of breast cancer and a 1.85-fold greater prevalence of all cancer among female orthopaedic surgeons. In 2015, Professor Chu expanded their study to include US board-certified urologists and plastic surgeons and found the results were not replicated among other surgical specialties. British orthopaedic surgeons Hamid Zada and Timothy Briggs also conducted a cross-sectional survey of 334 British orthopaedic trainees and surgeons. They found a significantly higher prevalence of congenital abnormalities among the offspring of orthopaedic surgeons compared to both national data and a control group of age-matched obstetricians and gynecologists. In order to contextualise the results of this review, we also compared radiation exposure and lifetime excess risk of fatal cancer between orthopaedic surgeons and pilots, one of the most regulated professional industries exposed to occupational radiation. The maximum annual radiation dose for the general public is 1 millisievert, increasing to 20 millisieverts per year averaged over 5 years for individuals exposed to occupational radiation. Many factors affect the dose of intraoperative radiation, including the screening time, distance from the patient's size, and the positioning of radiographic equipment. The bottom left table lists the mean published doses of radiation exposure per procedure for a surgeon wearing a dosimeter underneath a lead apron. The table on the bottom right is the average dose of radiation received per pilot for a pilot flying from London to Melbourne with a stopover in Singapore. Orthopaedic surgeons were found to have approximately a 3 times greater lifetime excess risk of fatal cancer compared to pilots flying long-haul international routes. All included studies acknowledged the limitations of their results, including the recall bias associated with the self-reporting of both fluoroscopy use and the incidence of disease. There are notable challenges quantifying dose responses of occupational intraoperative radiation exposure and the onset of diseases such as cancer, including the significant time delay between radiation exposure and the onset of disease, and the multifactorial nature of carcinogenesis. All included studies discussed the impact of multiple confounders, including nulliparity in the incidence of breast cancer in Chu et al., and the limited representation of female surgeons in the Zada et al. Paper. Importantly, none of the studies analysed in this review mentioned or discussed radiation hazards for pregnant staff, which highlights the uncertainty and challenges of occupational radiation exposure for pregnant surgeons and trainees. To conclude, this study demonstrates that the judicious use of appropriate PPE is paramount, and regular education regarding the hazards associated with frequent intraoperative radiation exposure is important to minimise inadvertent exposure. The potential hazards of radiation exposure identified in this study reinforces the need for standardised national radiation safety guidelines for surgical colleges to protect the health of current and emerging surgeons. Thank you very much for listening, and thank you to my supervisors.
And thank you very much for that. Another interesting presentation, particularly one that uses PPE for something other than N95 masks and goggles. Questions from my fellow judges?
Thanks, Sophia. Did you, in terms of other doctor groups that have high occupational radiation exposure, did you look at the interventional radiology, cardiology type groups? Because obviously they're doing a lot of angioplasty these days, and so very close to a C-arm for a lot of time. And, you know, the following question is, if you did look at them, did they also have the same kind of things seen with the orthopedic group, or did they fit with the other surgical specialties that didn't have that increased cancer prevalence?
Yeah, so we did actually do a subset analysis looking at interventional cardiologists and radiologists and even radiographers, and found that their results mirrored like the urologists and the plastic surgeons in the Loretta et al. Paper, in that there wasn't any significant increased incidence of cancers. And some of the published studies postulated that a few factors that might have contributed to these results were things like increased compliance with things like dosimeters among these subset populations that have a higher than usual exposure to radiation, and the PPE that they're actually using. So a lot of interventional cardiologists, for instance, nowadays are using lead goggles, whereas that's not really commonplace in like an orthopedic theatre, for instance. And so they raise these points as potential reasons as to why they're not mirroring people like orthopedic surgeons.
That sort of leads into my next, I'll call it a semi-question or semi-comment, as in an interventional radiologist is likely to have their own tailored lead gown that's got their name on it. The orthopedic ones are invariably the ones covered in plaster lying on the floor. Reasons for that are many and varied, but you know, you got to wonder if that might influence it as well, that the lead gowns being worn by orthopedic surgeons are pointless.
Oh, absolutely. And it cropped up on multiple occasions that not only do the lead gowns often not fit the person who's wearing them correctly, or do they have micro cracks in it that aren't being monitored as frequently as we think they are. And all of these factors contribute to how much radiation we're actually exposed to.
Thanks. Damien, did you have any questions?
Yeah, thanks, Sophia. I just wanted to ask, how do you see this fitting with or adding to the guidelines available from the Environmental Protection Agency, for example?
Yeah, so I think the Environmental Protection Agency guidelines should underpin any of the guidelines that, you know, are provided by not only surgical colleges, but by like the College of Radiologists. And they do. A lot of the principles that, for instance, the Royal Australasian College of Radiologists have developed their guidelines on are those EPA principles. So things as like using as low a dose as reasonably possible, the ALARA principle for radiation exposure, they feature very prominently in the guidelines that are currently out there. And so I think you cannot develop a robust clinical guideline that ignores what's already out there. I think it would have to underpin any guideline that, you know, surgical colleges would produce.
Yeah, so I guess what I'm alluding to is, why are we not just adopting those guidelines that are already there?
I think we adopt the principles of the guidelines, but we don't enforce them to the same rigor that I think other professional industries do. And I think that's potentially an interesting point, in that, you know, we do get told, put on your lead apron, you know, stand back as far as possible. But I think there's factors is a lot of people don't understand why, and maybe that then plays into compliance, because it's not kind of spouted as a this is actually really, really, really important for these particular reasons. So I think we're getting there, but we're not as good at it as we could be.
So it sounds like the issue is more one of awareness and education.
I think that's definitely a component of it as well. I think, like I mentioned, this is a highly complicated issue with a lot of different factors that are contributing to it. And I think, yeah, not only PPE being a big factor, but education and then compliance being another really important factor into where this goes.
Okay, thank you.
Yeah, thanks for that. And thanks for that, Sophia. Thanks for posing an interesting question. If we could move on to the next presenter now, it will be Andre Lojinwei. Are you there?
Yep, I'm here. Can you hear me?
I hear you, and I can see your presentation. So whenever you're ready.
All right. Good evening, everybody. Today my name is Andre. I'm one of the final year medical students from Monash University, currently placed at Eastern Health. Today, I'll be talking about my meta-analysis and systematic review entitled Comparison of Dynamic versus Static Fixation of IM Nailing in Tibial Diaphyseal Fractures. A special thanks to my research mentors as follows. I have no conflicts of interest to declare. IM nails for tibial diaphyseal fractures have two main fixation methods, mainly static and dynamic. In static fixation, all proximal and distal locking screws are implanted in circular screw holes within the IM nail, as shown in the picture. Some studies have showed that this might offer a bit more stability to the IM nail. And in dynamic fixation, the shaft screw is implanted in the oblong hole, as shown in the picture. And what this does is that it allows movement of the IM nail with respect to the shaft screw within the oblong hole. And some studies have suggested that this can increase interfragmentary contact at the fracture site. So our main aim was to assess mean time to union, while secondary outcomes that were assessed include complications such as non-unions, delayed unions, malrotations, and reoperations. These were our search terms that were inserted into 3 different databases. Screening was conducted according to PRISMA guidelines and pre-identified inclusion and exclusion criteria. Full text screening was conducted and the results were analyzed using fixed and random effects models. This is our PRISMA search flowchart. So after removing duplicates, there were 2,089 studies that were analyzed, and a total of 9 studies were included in the final analysis. Of these 9 studies, there were 712 patients, 478 underwent static fixation, while 234 underwent dynamic fixation. Mean age was 36.5 years, a population of young patients. There were more male than female patients, and there were more fractures of minimal comminution grade than high comminution grade. Mean follow-up was 13.3 to 21 months with a minimum of 4, and many different types of IM nails were used across the studies. In terms of our primary outcome, there was a significant mean difference of 5.18 weeks favoring dynamic fixation. In terms of our secondary outcomes, malrotation and reoperation rates, there was a significant result favoring dynamic fixation as well. In our other secondary outcomes, there were no significant differences found between dynamic and static fixation. So our study demonstrated that there was significantly earlier time to union in dynamic fixation of tibial IM nails. Other studies have suggested that the reason for this will be the fact that dynamic fixation allows for interfragmentary motion, as mentioned earlier, and this can increase the contact and compression at the fracture site. Ultimately, this can encourage stronger callus formation during secondary bone healing. However, in other studies, dynamic IM nailing has shown to have a higher risk for rotational instability. While this was not demonstrated in our study, this requires further corroboration as there was a small number of such complications within our population. In terms of static nailing, these can act as stress shielding devices, which can ultimately help to decrease the load at the fracture site. According to Wolff's law, this can reduce the strength of the fracture site during bone remodeling and can lead to further refractures. There is also shown to be higher rates of screw breakages in static nailing systems as the strain is placed across the static nailing configuration rather than at the fracture site. Despite the benefits that dynamic IM nailing might offer, it may not be suitable for all fracture types. It is perhaps most suitable for limited comminution, as static nailing can provide more stability in more severely comminuted fractures. Moving on to the limitations, heterogeneity of studies must be considered. As mentioned earlier, there were different grades of fractures, demographics of patients, and brands of nails that were difficult to control for due to the studies, the design of the studies that were included.
1 minute remaining.
Patient selection bias must also be considered. As static fixation is often chosen for complex fractures, this can lead to a longer time to union. Static fixation are also more likely to undergo secondary dynamization, and this might explain the lower rates of reoperations in dynamic fixation. Finally, some included studies were dated as well. In conclusion, our study demonstrated that dynamic fixation methods can reduce time, significantly reduce time to union in tibial diaphyseal fractures than static fixation. There can also be fewer reoperations and malrotations than in static fixation. However, further research on identifying patient factors and fracture patterns that will best benefit from dynamic fixation is required. Thank you very much.
And thank you very much for that presentation. Questions?
Thanks very much, Andre. I noticed quite a few of the papers that you were referencing in your review were, from the mid-90s. So is this question something that had sort of already been kind of established and dynamic fixation is the current state of play, or had that sort of 20, 30-year-old evidence largely been ignored and people doing what they wanted, and therefore you're trying to hammer home the message?
Yeah, thank you for that question. That was a limitation that we did arrive at the I mentioned earlier. So we have recognized that there has been significant surgical bias when it comes to picking dynamic versus static fixation methods. And this bias is especially so when when we are deciding between dynamic and tibial fixation in more highly comminuted fractures. And there's a prominent surgical preference to select static fixation over dynamic fixation in more comminuted fractures. And this might be the reason why there hasn't been a systematic review that, as of our knowledge, this is the first systematic review that has ever been done on the topic. And a few of these studies that we included did acknowledge some of this surgical bias. So it is important that we kind of just put in place some evidence to support to give some support to some of this the underlying practices that already are in place in the in managing such procedure fractures.
Surgeons are good at EBM, aren't we? Eminence-based medicine.
That's correct.
Thanks for that. Damien, did you have any questions?
Yeah, thanks very much, Andre. I think this is also a bit of a comment, I guess, but you touched on it and expanding on what Dan's already said. There's, in terms of some of the limitations of your meta-analysis, there are a lot of confounding factors with trying to have a standardized approach. For instance, with spirals fractures, dynamic fixation appears to increase the risk of shortening the limb. So based on what you've done with your meta-analysis so far, do you really think it is going to be possible to have a standardized approach, or are there just too many sort of patient factors and fracture factors that will prevent you or future research from being able to say, in this setting do dynamic, in this setting do static?
That's correct. Yeah, that is a recognized limitation. And this was also due to the fact that most of the studies that were included in our study, they were retrospective cohort studies. So it is relatively difficult to control for the confounding factors. And we've tried to do so as much as possible using fixed and randomized effects models. But what I would say that the main aim of this study would be setting the ground for further research in determining what kind of patient profile and what kind of fracture profile would best benefit from dynamic or static fixations, because this is still the first study to establish in the fact that there is established benefits of dynamized fixation compared to static fixations when managing tibial diaphyseal fractures. So future studies can further build on this result to further analyze what kind of fracture patterns and what kind of patients would best benefit from this these fixation configurations.
Thank you.
Okay, thank you, Andre, for that. Thanks for your presentation.
Thank you.
We'll move on to the next presenter. The next presenter is Nicole Chu. Nicole, are you there?
Is that working well?
It says you've started. There it is. Yes, we can see it now. So whenever you're ready.
Sure. Okay. So good evening, everyone. I'm Nicole. I'm a Monash medical student, and I'll be presenting on the validation of the Tokyo guidelines for cholangitis in an Australian cohort. And this project would not have been possible without the kind surgeons at Eastern Health. So Tokyo guidelines are a standardized criteria for diagnosing and grading the severity of cholangitis. It was most recently updated in 2018. So its diagnostic criteria consists of 3 components: inflammation, cholestasis, and imaging findings like biliary dilatation or causes of biliary stasis. The existing literature for this criteria consists of large, mostly Asian studies, which have demonstrated a high diagnostic accuracy of the criteria, however, has yet to be validated in an Australian population. After diagnosing cholangitis, the guidelines suggest that the patients should be prognosticated and have a severity grade given to them. So grade 3 cases are those with organ dysfunction, grade 2s have high inflammation or high bilirubin, and grade 1s have none of these. So a large-scale Japanese study demonstrated increased mortality with increasing grade. However, the literature in this area remains scarce. The guidelines also suggest that the grades should define and determine management. So grade 3s and grade 2s should get early or urgent biliary drainage, whereas grade 1s can afford a delay. So studies have shown that, interestingly, there is a decrease in mortality with early ERCP for the grade 2s, but not for the grade 1 or 3s. And a recent meta-analysis demonstrated better outcomes with early ERCP, but did not stratify this by grading severity. So the aims of this study was to firstly evaluate the diagnostic accuracy of the Tokyo Guidelines diagnostic criteria, evaluate the prognostic value of its grading severity criteria, and determine an optimal timing for ERCP for cholangitis. So we conducted a retrospective chart review of all emergency ERCPs at Box Hill from 2016 to 19. We primarily included cases of clinically documented or diagnosed cholangitis, but also a smaller subset of obstructive jaundice that was retrospectively fulfilled the criteria, but was not initially diagnosed as cholangitis. We collected key data in association with our aims, namely data to assess for the criteria, time from admission to ERCP, and mortality and length of stay outcomes. We had a total of 363 patients with an elderly population of 77 years for median age, and gender was equally distributed. Half of our patients presented directly to Box Hill, but half were transfers from other metro or rural hospitals. Most of our patients were grade 2 moderate cases at around 60%, and most of our patients received an ERCP within 72 hours of admission. So the first thing we looked at was the diagnostic accuracy of the Tokyo Guidelines criteria. So we started with our gold standard of clinically documented and diagnosed cholangitis, and we retrospectively applied the Tokyo Guidelines criteria to these. So the criteria picked up 99% of the cases, with 73% as definite diagnoses. So this was similar rates to the previous studies, and this shows that the diagnostic criteria does have a fairly high diagnostic accuracy. We also identified an extra 59 cases that were not initially diagnosed as cholangitis, but retrospectively fulfilled the Tokyo Guidelines criteria. So this just shows how difficult it can be and how complex it can be to make that diagnosis of cholangitis, and the importance of having a standardized diagnostic criteria. Secondly, we looked at outcomes against grading severity. So we looked at in-hospital mortality, hospital length of stay, ICU admissions, and length of stay. We demonstrated an increase in hospital length of stay and ICU admissions with grade 3 cases. So This shows that the Tokyo Guidelines severity grading criteria indeed picks up these higher risk cases with poorer outcomes. However, there's no significant changes seen between the grade 1 and 2s. Lastly, we look at timing to ERCP against outcomes and stratified by grade. So looking at hospital length of stay, we showed that an earlier ERCP conducted at less than 48 hours did reduce hospital length of stay for both grade 2s and grade 3s. And this is in line with the Tokyo Guidelines that suggest that grade 2 and 3 should get an earlier ERCP. We showed no increase in in-hospital mortality or ICU length of stay with delay to ERCP. We did find an association between ICU admissions and earlier ERCP. However, rather than suggesting that earlier ERCPs lead to ICU admissions, it's more likely that the cases that were deemed to require ICU admissions were clinically rendered as high risk and clinically decided that management should be escalated to urgent ERCP.
1 minute remaining.
To conclude, referencing back to our 3 aims, we demonstrated a high diagnostic accuracy of the Tokyo Guidelines diagnostic criteria, and this is possibly the first validation of the Tokyo Guidelines in an Australian population. Secondly, we showed the prognostic value of its grading severity criteria, particularly in identifying those grade 3 cases with the longer length of stays and ICU admissions. And lastly, we showed that earlier ERCP conducted less than 48 hours from admission can reduce hospital length of stay. However, there are no other mortality or morbidity outcomes associated with the delay in ERCP. Thank you very much for your time, and I'm happy to receive any questions.
Thank you very much, Nicole, for your presentation. And I'll ask if there's any questions.
That's a really interesting study. Thanks for presenting it. So the group of patients that you decided to have cholangitis based on the Tokyo Guidelines, but not based on their diagnosis, do you think that that is A, a clinical misdiagnosis, B, a Tokyo Guidelines misdiagnosis, or C, it was just never written down anywhere because modern documentation is not exactly crash hot?
Yeah, so that's a really good question. I think it just raises the point that it's really complex when it comes to diagnosing cholangitis. In fact, when we were looking through the charts, a lot of cholangitis cases there was cases that seemed like cholangitis, but people would never put down the word because they just didn't want. They would say that obstructive jaundice, cholecystitis was very difficult. It seemed very difficult for people to write down that it was cholangitis because of certain implications of that with severity and ERCP. So to answer your question, I think it's definitely a mix of both. I think there are those cases where they did seem more severe, however, people never put down the name cholangitis. There is also a chance that Tokyo Guidelines in itself has its own, limitations. It definitely can't identify every single one. There will be false positives as well. So it's definitely somewhere in between, and that's why it requires more research in this area to make the diagnosis even more certain and specific.
So that sort of leads into the second part of my question. So you concluded that the Tokyo Guidelines had a 99% diagnostic accuracy, but what it's not kind of sort of set up with like the, true positive, false positive, true negative, false negative kind of rate. I think what you really said is that there's a concordance with the patients clinically diagnosed with cholangitis that they meet the modern Tokyo Guidelines. And that group that met the guidelines and didn't get a diagnosis of cholangitis, did they proceed to ERCP?
Yeah, so there was an inherent bias in our study is that we started with a chart review of all emergency ERCP cases. So all our patients already had an ERCP. So there was definitely a bias in the fact that we weren't looking at those cholangitis cases, like grade 1, mild cases that never got an ERCP. So yeah, those that we picked up, all of them got an ERCP. And I think it raised a really great point about the fact that our diagnostic accuracy doesn't really give us any of that sensitivity or specificity. So we kind of modeled our study based on the Tokyo Guideline study itself, the one with the 6,000 cases, where they just looked at cases of cholangitis and then applied the criteria retrospectively. However, prior to that, they did have a study with around 1,000 cases where you had the cholangitis cases and the non-cholangitis cases, and that was how they were able to get false positives, false negatives, sensitivity, specificity. But unfortunately, we haven't done that yet. But it's definitely a step that we can take.
Damien, any questions?
I was going to ask, thanks again for your talk. It was very useful. I was going to ask, in terms of your analysis for length of stay, did you account for lag bias in the sense that if you took out the time it took to get to ERCP, would that change the statistical significance of your length of stay outcomes?
So that's a really good point, which we also considered, but we have yet to actually do the statistical analysis for it. But definitely there's a question of like, is the increased length of stay, is it because of increased mobility, or is it just the delay in ERCP? However, just looking at the data we have so far, so especially for the grade 3 cases, the difference in length of stay was quite significant. So although the intervals were maybe only 1 day apart, so saying those that had ERCP within 24 to 48 versus those who had within 48 and 72, the length of stay difference was around 6 days. Whereas if it was just because of the delay and the lag, it will only be a maximum of 1 or 2 days. But definitely we still need to do further statistical analysis because it is a confounding factor.
Thank you.
Okay, thank you very much for your presentation. That's really interesting. And we will move on to what will be our last presenter of the night, which is Aparajita Tomar. Are you there?
So good evening, everyone. I'm Aparajita Tomar, a final year medical student from Monash University, and I'm here to talk about a research I've been involved in with Monash Health and Peninsula Health, titled Outcomes of Collagenase Use in Dupuytren's Disease, a large multi-institutional cohort study. So as we all may know, Dupuytren's disease occurs due to pathological fibroproliferation of the palmar fascia and manifests as palpable nodules, cords, flexion deformities, and contractures of the hand. While multiple treatments for Dupuytren's exist, a relatively new non-surgical treatment modality has been gaining interest in the recent years. Collagenase Clostridium histolyticum injections are a mixture of two collagenases, AUX1 and AUX2, that can cleave collagen in the diseased palmar fascia such that, with physical manipulation, the cords can rupture and result in correction of extension deficits. Efficacy of collagenase injections has been well established in the wider literature. However, no universal treatment protocol exists. Therefore, given the increasing interest in this treatment modality, our study was conducted with a purpose to assess outcomes of existing protocols, evaluate any differences in response achieved by these protocols, and ultimately direct an efficacious and standardized treatment course based on our results. So to do this, we conducted a retrospective cohort study at 2 public hospitals in Melbourne, Australia. These will be referred to as Institution 1 and 2 from this point. We included patients treated at the institutions with collagenase injections between the period of 2016 and 2021 and assessed them for the outcomes of this study pre-treatment and then at 6 months post-collagenase injections. Our primary outcome was reduction in passive extension deficit. I would be referring to this as PED from this point. This outcome was assessed in 4 categories. First, as a combined PED, which was essentially just the PED value for each digit derived from adding per joint values. Then we looked at the percentage change that occurred in combined PED after treatment. We also assessed clinical success, which was defined as a less than 5-degree combined PED remaining after treatment, and also looked at clinical improvement, which was defined as a greater than 50% change in combined PED after treatment. The secondary outcome of this study was patient-reported outcome measures, which were assessed through a questionnaire. This questionnaire was an adaptation of the URAM scale that has been widely used to evaluate global hand function. Patients were given a percentage of total URAM score based on their answers, and the lower the percentage score was, the better the hand function was noted to be. So with this methodology, we aimed to determine if there was a difference in the efficacy and outcomes of collagenase treatment between Institution 1 and Institution 2. As for the results, after analysing data from 557 patients and 840 digits, we found that collagenase injections improved PED and percentage URAM scores at both institutions. We can observe in graph 1 here that the median combined PED reduced significantly at 6 months for both institutions. And similarly, we note in graph 2 that the median percentage total URAM score also was lower significantly post-treatment at the 6 month time point for both institutions. Now, if we compare outcomes between the 2 institutions, we can observe significant differences as illustrated in graph 3. All treatment outcomes were positive for both institutions, indicating the efficacy of collagenase injections. However, the magnitude of this positive effect was significantly greater at institution 1 compared to 2. We can note that at institution 1, which was the green teal coloured boxes here, the percentage change in combined PED and the frequency of clinical success was greater compared to institution 2. And the percentage total URAM score was also lower in comparison to institution 2. Frequency of clinical improvement was the only outcome which was better at institution 2 compared to 1. However, this difference was not significant. With regards to these results, I would like to highlight 2 aspects that may have influenced the trends we have noted. Firstly, institution 2 had a cohort with a significantly greater baseline severity. We can see this in the pie graphs here. At institution 1, majority of the patients treated were of grade 1 disease, compared to institution 2, where a greater percentage of patients with higher grades of severity were treated. This is important to note because a lower baseline severity has been associated with a better response from collagenase treatment in the wider literature. Secondly,
1 minute remaining, sorry.
Multiple protocol differences were present. Importantly, compared to institution 2, institution 1 had a longer duration between injection and manipulation and employed use of formal hand therapy and splinting, with a correlating greater treatment effect in clinical and patient outcomes. This implies that the time the injections have to work before manipulation and post-treatment rehabilitation may be important factors to consider in future protocol designs. So in conclusion, in this study, we found that collagenase injections were efficacious in reducing PED and improving patient perceived hand function, irrespective of protocols they were delivered under. However, the magnitude of effect that was achieved was different. Examining specific variables to underpin which ones contributed to differences in treatment was out of the scope of this preliminary study, and therefore future directions from the study include direct examination of protocol differences and their correlation with outcomes, and also assessment of important characteristics of this pathology, such as recurrence through examination of longer-term data. Ultimately, the goal is to provide evidence for development of a strengthened and standardized protocol that yields maximal treatment efficacy of collagenase injections. Thank you, and I'm open to questions now.
And thank you very much for that presentation. Questions from the judges?
Thanks very much. That was obviously some pretty major differences between the 2 institutions in the protocol, in particular hand therapy, when you're assessing passive extension. With the absence of hand therapists, how was the degree of passive extension measured?
So at the institutions, they did have a session before the actual treatment. They did have a session with, for institution 1, they did have a session with a hand therapist where the hand therapist measured passive extension deficits through goniometry, and then the registrars and consultants who were delivering collagenase injections also measured them. So they had a pre-assessment visit where goniometry was done to measure passive extension deficit at institution 1, and I believe this was the same at institution 2. However, it wasn't specifically done through a hand therapist, the goniometry measurements.
And was the other question to ask, I suppose, was there a technique difference in the way the injections were administered in terms of confirming the locations for the injection that have contributed to the difference that you've seen? We didn't, so in this particular study, I didn't go into all of those differences that much. So they were a little bit out of, I think there were some differences because I think there were a few differences where one institution was treating one hand at one time per visit, whereas the other institution was treating bilateral hands. So they were using more doses and more injections, and sometimes the injections were, just split between the cords. So there were all these little intricacies which I didn't particularly go into at this point in the study, but as I mentioned, would definitely be an important thing to look at in a future study design where we could possibly prospectively go in and analyze specific protocol differences separately and control for them. Thank you.
Okay, thanks. Damien, any questions?
Thanks very much for your presentation. I mean, obviously one of the limitations is the difference in treatment protocol between institution 1 and institution 2 and the difference in severity of disease. Did you go on to do a subset analysis to account for those differences in terms of outcomes?
So in the calculations, when the data was statistically analysed, baseline severity was taken into account through the formulas that were used to calculate like the percentages and everything, but there was no specific subset analysis to look at baseline severity and different grades as such. And again, that is what I highlighted. These are the two things that have popped up that are different. And given that we have seen that the two different protocols have resulted in significant differences through this preliminary study, now we should go in and see how much of an effect these differences have, and if controlled for, does this effect still occur?
Thank you.
Okay, yes, and thank you very much for your presentation. And that brings us to the end of the presentations for this evening. I think first of all, I'd like to thank my my colleagues who are acting here as judges for their time and concentration tonight. And I'd like to thank all the presenters for the obvious effort that you've all put into the work behind these presentations and to the presentations themselves. It's always a difficult format to use, this format, but everything has come across really, really well, and so you deserve hearty congratulations. The recording will be put onto the college website, and once all of the presentation sessions have been completed, and there's 3 of them, we will advise all the prize winners by email. But that brings this first session of presentations to an end, and thank you all for attending.
Yeah, I agree, Matthew. Very high quality presentations across the board. So well done, guys.
Yeah, good job, everyone. Well done.